My name is Professor Adetola Kassim. I work at Vanderbilt University Medical Center, the bone marrow transplant director, and a hematologist oncology by training. In terms of the role I played here, I consider this a team sport. I'm not going to use the word developing. I think the time was right. With the help of people like Professor Akinyoju, the current director for the Sickle Cell Foundation, Annette, and the Lagos University Teaching Hospital, I think it was an opportune time to focus on curative therapy for sickle cell disease. What surprised me in all this was the fact that initially when I raised the concerns about having the local expertise, the deeper we looked, the more I found that we actually had people who were knowledgeable, competent, and could clearly be, trained to be able to help support and provide these services in Nigeria. And to date, that has not disappointed me. And so what we did was form a collaboration with Vanderbilt Medical Center, where a lot of the providers have been going back and forth for training and kind of invested over the years in trying to get them up to speed on what to do. Transplant, I always say, is a team sport. One person, it has really four main parts when you look at transplant. You have the clinical program, where you manage the patients. That itself is broken up into two. When the patient is actively undergoing transplant, and after the transplant is done, how to ensure the patients stay alive and they do well. So that's one bucket. The second critical bucket is having a transplant facility itself, where they undergo transplant itself. And you have a bone marrow unit here. Obviously, to do the transplant, you need to have what is called a processing lab. They are the ones who receive and get the product ready to infuse after a donor has donated the bone marrow stem cells, right? The other piece of the puzzle, apart from that, are some of the laboratory support, right? You have things like the HLA lab, that also should be able to do that. We have what is called the apheresis unit that can also perform apheresis and collection from the family members or even the patient if need be. And another critical component of that is the blood bank. So over the years, what we've done is methodically go through identifying proficient people in these areas, supported them with training so that they're really competent and ready to meet the goals. Obviously, they won't do the volume like we do starting off, but I think over time they'll get there. You make progress in small quantum leaps. Myself as a professional, what's more important to me is I don't want to be part of any pseudo default program. And I always said it from day one, if you're setting up a transplant program, it's got to be within a teaching hospital facility. So I made that crystal clear. And I think both the Sickle Cell Foundation as well as Lagos University Teaching Hospital understood that, because that's where you have a lot of the expertise in all the disciplines you need. And within those areas is how you bring out people for a common purpose. My sense is, with the level of education I see amongst Nigerians and their level of expertise, I don't foresee a situation where they can't do this. Literally almost every country now, at least within Asia, they have a transplant program. Nigerians are going to India all the time to do it. But what we've not asked is, what's the competence of the places they go to get a transplant compared to a facility here? Nobody checks that. So my goal is not to legislate between what is in the US, Europe, or India. My goal is to say, let's provide a cost-effective, efficient, and very effective program in Nigeria, which is locally adapted and is giving us outstanding results. That's what's important. Obviously, there are going to be differences. With high-income countries, they will do things differently. And that is why, having good discussion with the team here, looking at what works for us here, what doesn't work for us here, are critical steps to be able to make a very informed decision about what is most important for us. So I'm very confident we can do this well, especially if we have both the public and institutional support that is required. One thing that has happened in the last decade, both in the US and Europe, is the fact that even though we've approved different medications for sickle cell disease, it hasn't changed the lifespan of the adults with the disease. Adults are still dying at a higher rate than any other disease, despite taking all these other adjunctive support measures. So the question that was being asked was, in high-income countries, is, I think we should think about curing this disease because it has all the profile of a disease you can cure. And once that is done, and it's now been proven that this works in terms of cure, there are also other new curative therapies in the horizon. Then the critical question you have to ask is, if you have 110,000 patients with sickle cell disease, or let me put it in a better way, the burden of sickle cell disease in the whole world that was documented is 8 million throughout the whole world. 75% of those people live in sub-Saharan Africa. So only 25% live in other countries. So if you've now validated a cure for a disease and you're saying that it makes a difference, then you have to ask yourself the critical question. Why do you want to deny the 75% that cure? I think it's an ethical problem. So the challenge is, yes, it's expensive. Most other countries support transplant programs through a public-private governmental venture. That's what we need. I'm not advocating transplant for every sickle cell patient, but we clearly know that there are patients with sickle cell disease that the only answer for their disease is to cure them. Those are the patients we should focus on first. As we make progress, then there's going to come a time when patients can ask the question, do I just want to stay on medications or do I want to get a cure? But right now, we're in a learning curve. I have full confidence Nigerians are competent to pull this off. I'll give all my support and all the support I have in the professional medical world. But we have to make a decision for ourselves. Do we want to just neglect people with this disease here and pretend nothing exists and leave the cure only for Nigerians who can afford to go abroad and do it, which it costs over $500,000, or come up with a cost-effective strategy like it's being done in Turkey, India, just name it, and put this here. And with time, we'll get proficient at it and we'll be able to at least offer this for our patients that need it. The choice is ours.